Hello, and welcome to another episode of No Notes, where the conversation is always a perfect 10 out of 10. This podcast is powered by Elios, the most used and most loved AI platform in behavioral healthcare, equipping more than 230 organizations and nearly 40,000 providers with powerful automation tools that streamline documentation, simplify compliance, and surface deep care insights that drive better client outcomes. I'm your host, Dr. Denny Morrison, and today we are diving into a topic that's foundational to substance use treatment, but often overlooked in broader behavioral health conversations, and that is group therapy. As a former group therapist, this is a topic near and dear to my heart, so I'm really happy we're getting into this today. With me today is Dr. Janice Ruesler, Director of Education and Special Initiatives at Gibson, a Missouri-based SUD provider serving a largely rural population. Janice has led Gibson's Elios implementation and is helping the organization expand its use of AI across both individual and group services. Today, we'll explore the efficacy of group therapy, the realities of delivering it in rural settings with workforce constraints, and how Gibson used Elios's groups functionality and NDE to reduce documentation burden, improve clinician experience, and support high-quality addiction treatment. So welcome to the podcast, Janice. We're really happy you're here.
Good morning. I'm excited to be here with you all today.
So tell us a little bit about Gibson.
So we are based in Southeast Missouri. Gibson Center for Behavioral Change has been a cornerstone for recovery since we were founded in 1979. We serve about a 5-6 county area in Southeast Missouri. Our patient base, most of our, if not all of our patients have substance use disorders, co-occurring disorders, and most of our patients are also justice involved individuals. Those individuals kind of referred through drug courts or probation and parole. So we use a continuum of care model where we provide residential, outpatient, as well as wraparound services. And within those menu of services, we also provide group therapy.
Cool. And tell us a little bit about your background. How did you get to be at Gibson? How long have you been there? What's your educational background?
Yeah, so this is my second tour of duty of Gibson. That's what I call it. The first time I worked here for about 6.5 years in various leadership capacities, case management, outpatient director. I left for about a year and a half, and then I came back, and I've served as the outpatient director, and I'm currently the director of educational and special initiatives. So my background, I have a bachelor's in psychology, master's in counseling, and a PhD in counselor education and supervision. And so my role, I work a lot with our student interns, student placement. But the other part of my role is working in all of our special initiatives, which is things around grants, new service implementation, program implementation, but also programs like Elios, where we can help enhance staff capabilities and provide ways to make their jobs easier and more manageable.
Great. What a great background. So, you mentioned that the large proportion of your clients are suffering from addictions in one form or another and possibly co-occurring disorders. And I suppose that group therapy is kind of the cornerstone for your treatment interventions for that group. Is that correct?
Yeah, especially for our residential. As you know, group is not just a collection of people sitting in a circle, but it is a psychological tool that drives change that sometimes can't be addressed within individual therapy. So, in residential programming, we live and breathe recovery processes 24/7. That group process becomes a catalyst to their healing and their recovery. Addiction thrives in isolation. And so, for us being able to bring the men and women into groups, into hearing other stories, it helps reduce shame for them and helps them find this understanding that they aren't broken, but instead they have regular symptoms, just like other people around them. So it provides that safe space not only to practice those skills, but also skills around belonging and finding ways to connect to others as they move through their recovery process.
Yeah, as I mentioned in the intro, I was a group therapist, both doing addictions and then in a high functioning partial hospitalization program where group was the treatment of choice, and we did groups, uh, gosh, 4 hours a day, maybe. And I loved groups. I just loved the process. I loved the challenges of dealing both with what was going on with that individual and then the system of kind of interactions between people. That it was kind of a multidimensional uh, aspect of care. I
Mhm.
really didn't like the documentation much, though,
Right.
and
It's a lot.
I suspect I share that with a lot of group therapists, maybe in your organization. Tell us
Yes.
about how that process works for you. What's the documentation load like? And let's talk about that pre-Elios.
Sure. So, it depends on our groups. Sometimes we can have 10, sometimes we can have up to 16, 15. Sometimes even up to 20 individuals where we would have two facilitators in the room. But the way that our system works is you write a master progress note, kind of the who, what, where, why. And then it is applicable to everybody in the group. It then transports into everybody's chart. But then you also have to go back into each individual chart and give individual statements about each person. So if you're thinking about leading a group for 55 minutes and then you're supposed to have 5 minutes to do your documentation before your next session starts, the thought of having to write first off the overall group note is very overwhelming. But then to think that you're going back and adding 15 individual comments on 15 individual notes, that amount of time really starts to stack up on a clinician and can really increase the burnout factor for our staff.
Well, SUD is probably the primary utilizer of groups when we look at the behavioral health continuum.
Mhm.
We don't see it as much in behavioral health care. We mentioned this in the opening remarks, and I would suspect. I don't think this is the primary driver, but I suspect that the documentation burden is one of the reasons that group. If you have a choice between doing a group and seeing individuals, and you can still meet your productivity expectations by doing
Mhm.
individual, clinicians are going to default to an easier documentation process. Would you agree with that?
I would agree with that. I mean, if you think about it, I can write 1 note or I can write 16. And I get that same piece towards my productivity. What we do is we actually have individuals assigned to do various groups. That way they can't be like, "Oh, I'm gonna see an individual instead of do a group." And that way we try to break that group burden up over multiple staff. But then the reality of it is you look back, once again, you have that documentation burden, and then even though it's split out across all staff, then you have to worry about all staff's burnout on top of that. So yeah, our clinicians would probably prefer to do the individual just because of the reduced documentation burden. After Elios, though, we don't see as much resistance to groups because of the assistance and the reduction that it causes in amount of time that staff have to spend on their notes.
So how have you got any data that supports that? I mean, I'm sure anecdotally people are saying, "My gosh, this is easier," but do you have any estimates of how much quicker notes are being done?
Yeah, so the thing I love about Elios is the dashboard, and we can really go in and look at staff reduction time and things like that. And so I attempted to pull some numbers just overall, and just to give you a roundabout, when you're dealing with a single patient, yes, the 5 minute time save is nice. But when you're looking at moving that into a group format, so for example, we're going to say a 60-minute session with 16 participants, and Elio saves a clinician 6 minutes per chart. So you're talking about taking what may have taken almost 90 minutes to document um, down into 10 to 15 ish, maybe. Um, and we have some staff, obviously, that work at quicker paces and others that work at slower paces. But we're talking about reducing staff time on those notes by approximately looking at our dashboard around roughly 80% of reduction just in group notes. And so we're getting a lot less pushback from staff about needing to teach groups because of the Elios support. And so when you're talking about productivity basis, first off, it's great for the staff, but it's also great for a business's bottom line. I mean, we're talking about reducing staff time, reducing non-billable time, and actually the amount of time that they can earn back through using Elios is equivalent to a whole nother session that they could be doing. So it's really provided us the flexibility to not necessarily increase our staff's productivity expectations, but give the staff the time they need to meet their productivity expectations and lower that stress level of trying to do it all.
So speaking of productivity, and we touched on this just a second ago, when you in your organization, um, how do you calculate productivity for individual versus productivity for group? Because different organizations handle that differently.
Right. So for us, it's calculated the same way. So they get credit for the group. So if it's 55 minutes, we round that up to an hour. They receive an hour of productivity credit, whether it's group or individual. So they're not receiving more productivity credit just because there were more people in the group. And so that's why I think when you start to look at it from a business perspective and burnout perspective, you don't get as much pushback in groups then whenever they have documentation assistance available.
So we have heard anecdotally, actually some research that supports this, but we don't have it for groups yet. That clients of clinicians using Elios stayed in treatment longer. They were more engaged. Their outcomes were better. They had better, just generally better results. And we suspect that's due to the clinician not being preoccupied with writing a note, that they can be more present for the client, and the client perceives that, and consequently the therapeutic relationship is enhanced. Have you seen anything around those areas happen in your organization?
I wouldn't say that we've necessarily like tracked data in the limited amount of time, that we've used groups, but I can tell you like our patients' feedback to our clinicians is that they feel like the clinicians are more present. The clinicians aren't distracted in their mind about, okay, I need to jot this on a piece of paper to make sure that I catch it in my note. Um, and really like talking with our clinicians who are using groups, I use it as a tester, but also our clinicians using it is that it is really accurate. The beginning, you have to train it, just like any other AI based technology or supportive technology. You have to train it to learn how you want things said and what you want things to look like. So it takes a little bit of time in the beginning, but then afterwards, like the reduction in time that we're having is great. And I don't feel like I have to take a piece of paper in with me to group to jot down notes to remember to write what I need to write in my progress note that I may not to get to do because I have another patient afterwards or things like that. And so my patients, even not only in groups but in individual, has said, Janice, I really just feel like you're more connected to me, like you're not worried about jotting a note or anything like that. You turn the recorder on in the background and you're just present and here. And for me, that makes all the difference in client care is just that presence and people feeling that they're heard and listened to and not just a document that goes into their chart.
That's so good to hear, because I agree with you. It's like that's the bottom. I mean, I'm glad that clinicians are having tools to get their documentation done, but we're in this business to help others. And if others perceive this as helpful, that's a good thing. And I'm really pleased to hear that you've had that experience as well with clients getting a benefit, immediate benefit from this, not just kind of in the longer term. That's really helpful. So you mentioned that the startup, you mentioned like, there's some training involved and so on. Tell us, how did you start with Elios? Did you have a pilot group? Did you do a big bang approach and roll it out to everybody? How'd you do it?
So our overall Elios, we had a pilot. There was a group of about 5 or 6 of us that got on with Elios, went through some training, tested it in-house, gave feedback to Elios. So we call those people our champions. Myself and one of our data staff, were the 2 staff who led the project. So I tested it not only as like an administrator, but also as a user as well, right beside the rest of our pilot group. And we gave pretty active feedback to Elios throughout the process. Then what we did is when we rolled it out to the whole organization, we used those champions, not just myself and the other person leading the project as trainers, but those champions as well to be like, hey, if you can't get a hold of Janice, you can also call this person and this person who's been using it for a while. We found that rollout method to be super effective. One, because our organization is smaller. We have around 150 individuals in our staff. So if you're looking at an even larger organization, one person cannot carry all of that. So it helped spread that out, but it also helped create a message of hope to our staff So our staff who were testing were giving these things that were like, "Hey, I don't have to write my own progress notes anymore. It takes me this much time to do a note." And so other staff almost started getting jealous of not having Elios. So by the time Elios rolled out, everyone was excited and ready for it. Also in-house, we have those champions make just some little like video clips that we can send out to the agency about using Elios and what it looked like, so that other staff could kind of get a feel of how it was supportive. Obviously, you always have some staff who are, I wouldn't say resistant, I would say worried about utilization of AI and what it means for the protection of their clients and their patients. And so we spent some time with those individuals too, talking about, okay, Elios, while it does record, it doesn't save it, and helping set up those security processes so that the staff felt comfortable even sharing what Elios was with patients. When we switched and added in the group model, we did the same thing. So we took a handful of clinicians who were doing group services, and we're having them test it intensely. They met with the Elios rollout team, and talked about it, tested it in a room with Elios, where our Elios implementation person volunteered to be the patient. And we all just kind of did a group to see if how audio would catch, what things looked like in our group room spaces. But then those staff also did testing over time and provided active feedback about, this is what we like, this is what we don't like, this is the gaps that we're seeing, before we are including all staff, because we don't want to roll a product out until we know what it's going to look like within our environment. Because Elios is a great product, but over time it looks different for each organization and agency that's using it. And so we just wanted to make sure all of those kinks were worked out before we rolled it out for the whole organization. And so, like I said, using those champions is really what made the difference for us within the agency, building that positive atmosphere, addressing the fears, but building that positive atmosphere about empowering our clinicians, reducing burnout, and also improving the patient experience.
So it sounds like your groups range somewhere between 10 and 20 people. And
Mhm.
how do you handle the microphone situation in those larger groups? Do you have remote
Yeah.
mics or how do you do that?
So our agency uses units that are called owls. We bought them online. It has video option and audio option. We also have a large TV in the room that is connected to internet and has a essentially a computer box connected to it. So you can turn the large TV in the room into a computer. We also use it as a whiteboard and other functionality. But Owl is connected to that computer unit versus bringing in a laptop. Because obviously, if we have larger groups, our rooms can be bigger, there's echoes, things of that nature. But the Owl units have really advanced microphones that have noise canceling on them as well. So you're not picking up all the fan noise or other things like that. We can hear the quietest person in the very furthest corner of the room, and Elios picks it up just as well as if they're right beside the microphone in the space. So we have the OWL unit up on the wall, kind of behind the facilitator, so it's not in the middle of the group, it's not impeding the group process, but is still able to catch all of the audio portions from the group.
Have you identified like a break point in terms of number of users where you really need an owl device versus just working off of a computer microphone?
So in some of our other spaces, in one of our more remote counties, we have about 9 individuals, 10 individuals that come to group. What we found is if it gets larger than that, the laptop unit is not really good at deciphering names. So one of the things that we do at the beginning of the group is we ask each of our clients to go around and say their name before we start group. That way Elias can kind of identify voices as we begin the group. At first, it felt a little clunky and a little awkward for our clinicians, but what we found is it produced much better outcomes in the documentation process. So we just start off the group by saying, "Hi, I'm Janice, I'm the facilitator," and they each go around and say their first names. And then we move into the session like normal. Like I said, in those more remote communities, once we hit about 10, the laptop speakers just had issues deciphering who was who. So in most of our spaces, we use those OWL units because it has better outcomes.
Yeah. Yeah, I think, that's what I would have guessed. Somewhere around 8 to 10 is kind of like the sweet spot. If you're doing a smaller, say, process-oriented group, maybe one that has been together for a long time, you can get by with just a microphone on the computer for an
Mhm.
8-person group, let's say. But that's
Yes.
where I would have put it, right around 8 or 10. So that makes sense
Mhm.
to me. I think there's the technology is such that if an organization chose not to do that intro thing, which I don't think is a huge burden, but I know that sometimes clinicians don't want to change their workflow and so on. The AI will do as good a job as it can to infer like who's speaking. So if you don't introduce yourself, but I'm the therapist and I say, Janice, how was your week? And the next person who speaks, it will infer that that's Janice from that conversation without you ever saying, hey, I'm Janice. So
Yes.
it does work. But I think I like what you described. I don't think that's a huge burden for therapists. I don't, and
Mhm.
even if it's a no process group where they've been together, if it's a closed group where you're going to stay together for 10 weeks, let's say,
Mhm.
it still doesn't hurt to do that. So it's not a big deal.
Yeah, our patients haven't complained any about having to do it or feeling like it was a burden or anything like that. So, we do regular check-ins with them just to be like, "Hey, how is group going? How are things going? Is there anything that is impeding your treatment?" Things like that. And so, we have not had any negative feedback at all
Yep.
with anything related to Elios.
And one question that always comes up about using AI for documentation purposes is consent. How do you handle consent that in terms of disclosure about using AI? How, do you do that? Do you ask for consent? How does that work?
Yeah, so we actually, as part of our agency orientation process, we talk about Elios with each patient. It's part of our orientation that we have this AI documented support. And the way that we've explained it, and I feel like our patients have connected to it the most, is I explain it like talk to text. Okay. So I say, hey, if you get really bored of typing and you talk to text, it produces something, but it doesn't save your voice. It doesn't save any of that. Elios is the same way. It is talk to text. It helps me create my notes in the background. It doesn't save our session anywhere. It doesn't save, okay, John Doe said blah, blah, blah at this time. So I have explained it as a talk to text, and that's how other staff have started explaining, and we're seeing a lot more buy in. We also do an overall orientation with our groups once a week. Our residential groups. And in that, we do explain to them that we use Elios as a tool, that you will see some of our staff using the OWL unit in the room. What it is to increase the documentation experience and enhance their services and focus. So, if you explain it in a way that it is enhancing services for them, making the staff more focused on what they're doing, and helping explain that it doesn't store the data so that there's no fears, we found a lot more buy-in. I think we've had maybe 2 individuals who didn't want participation, who were, on the mental health spectrum, schizophrenia type spectrum with some paranoia, which makes total logical sense from a clinical perspective. Other than that, most all of our patients have been more than happy, to let Elios listen in and help us with the documentation process.
Yeah, that mirrors kind of what we see. Something on the order of system wide, around 2 or 3% of clients don't want to give consent, and almost to a person, they have some form of paranoid ideation. So that's not what you're experiencing is the same. I think a little bit unique to substance use is the involvement with the legal system. Do you have clients who are concerned their PO might hear about something they said in group? Or do you get any of that kind of thing?
Yeah, we do at times, and so the way that we explain it back is, anything from Elios is considered a part of your EHR. You have to sign consent, for them to receive those notes, things of that nature. It does not save the recordings, it does not save the audio, nobody has access to it, and a lot of people even explain it to as, some of our patients see multiple people, so they may see a case manager and a counselor and a mental health therapist. And they'll say, for example, as the mental health therapist, your substance use counselor doesn't even have access to what happened in our session and they're in house. And so just helping to reduce those barriers by clearly explaining the process of Elios and what it looks like. We haven't had anyone opt out who's just as involved for that reason.
I think erroring on the side of transparency is always the better tack. And I
Okay.
think and I love your talk to text metaphor. I think that's a great way to explain this particularly since none of that stuff is saved. It's, it just helps me create the note and then it goes away. So how did, what, in terms of, talked a little bit about your rollout process. And as you continue to use Ilios, what's your organizational policy about clinicians choosing to not use it, or can they choose to not use it, or how do you handle that?
They can't choose to not use it. So the way that we've set it up within the organization is this is a support tool that is expected for utilization. So all of our supervisors have access to the dashboard. They're expected to check it regularly. If they notice a staff is reducing or not utilizing it, they're expected to have a conversation with the staff. Why are you not using Elias? What are the barriers? How can I help you overcome those barriers? Because this is seen as a tool to support you, one, in your documentation process, but two, also in your staff wellness process. So we explain it as a support tool that is a required implemented piece of our agency. So our staff unfortunately do not have the option to choose not to use it. We had some staff I thought that were going to give pushback on that in the beginning, but honestly, after they tried it a couple times and saw the reduced burden and saw the way they could be present in sessions, that resistance really fell off over time. So, for example, if we have somebody struggling with productivity and we find out they're not using Elios, then we bring that back into the supervision conversation. So, yes, your productivity is struggling because you're spending so much time documenting, which tells me you're not accurately using Elios. So, sometimes what we'll do in our supervision sessions is kind of role play what an Elios session would look like. And then we have the staff pretend to write the progress note themselves to see how much time it takes versus what it would take within the system.
That's a good idea. That's a great way to get some real kind of in vivo training of,
Mhm.
here, you're doing it this way. Here's what you could be doing.
Yeah.
The, so it's kind of like treating Elios like the use of an EHR. This is the way we document here. You have to, you can't, we're not going to let you write notes on paper anymore. Sorry.
No. Yeah. Yeah, no, it's an integrated piece into our EHR, and it's an expectation that everybody uses that integrated model. We've tried to make sure that no matter what environment our staff is in, that they have access to utilize the Elios tool.
Yeah, just for the listeners, there's really two formats. One is the ambient listening, where it literally listens and then helps you create your note, and then there's the non-ambient listening, where you can just jot 6 notes or so, either by writing or speaking in any language, and it will create the note for you. Uh,
Mhm.
and you don't, in those cases, like what we see sometimes is that even if somebody who has given consent to use Elios might on some day say not today, and say an individual session, and the clinician still has a fallback tool to use to write the note, just using the bullet point format. So there's just to clarify, there's really two modes of entry, and they are synergistic. For mobile workers, the non-ambient listening tool is easily used on an iPhone and so on. So I just wanted to clarify that just for our listeners. So you in your rollout, and you mentioned that that you make this kind of a mandatory part. It's an expectation to do the job. Have you had any um, clinicians who you just thought would never adopt to it, who ultimately found it helpful?
Absolutely. One clinician comes to mind. He has worked with us for, gosh, probably at least 10 to 12 years with us, but has worked in the field for probably 45 years. And so when it first came out, he was like, Janice, I just don't know about this. Like, I think it's intrusive. I think it's invasive. Um, you all are going to be listening to my sessions. And so I was not for sure he was going to get on board. But he is one of the people that I was referencing earlier, where we kind of said, okay, I want you to try it. And then after you try it, let's come back and have a conversation about it. And really, what he found over time, he's one of our biggest advocates for it now within the agency. What he'll say, I'm an old man. If I can do it, anybody can do it. And he'll say, and it has increased my happiness with my job. It has taken away my burnout as much. I'm not spending as much time on documents. and I get to do what I like to do, which is be with my patients. So,
Let's hear it from the old
yeah,
guy.
yeah. So he definitely was the one where I was like, "Ooh," but really over time, he's become one of the biggest advocates for it within the agency.
I think, I mean, speaking of, there's always a question about whether there'll be a generational difference when you roll these things out that
Mhm.
people of a certain age, like some of us, might be a little more resistive. And I mean, this is the stereotype that they
Yes.
might be more resistive, and younger people would be much more willing to adopt it. In part because they already use AI in their personal life.
Mhm.
But have you found that to be true, or is it not as clear cut as that?
I don't think it's as clear cut as that. I think, I have individuals from all various generations that work here at the agency. And some of our younger generation staff are like, I use AI, but this is different. Right. And so, really, I don't think it's been necessarily a generational difference. I think initially our thought was there was going to be some
Yeah,
generational
yeah.
issues. But like I said, the one example I used, he has just become one of the biggest proponents of the utilization within our agency. And so we've really just seen the staff that have utilized it and worked at other, especially those that have worked at other community mental health agencies or other community agencies where they were writing their own documentation. And then they come in the door and they go through their orientation. They're oriented to Elios and they get to start using it the moment they start documenting. They have come back to our supervisors and said, this is so much easier than what I've ever had to do, and this really makes my job feel like it's a lot easier to do every day.
Do you get a lot of new clinicians that is new to the business to the like fresh out of school? Uh, um,
Yeah, yeah.
we've heard some concerns um, about from organizations. One organization comes to mind in particular, where they don't allow people to use Elios until they get past probation because they want to
Wow.
see them able to write a note the old fashioned way that they conceptualize care right without using Elios. And then once they pass probation, then they get an email or they get a login. Um, and so I was wondering if you have had any concerns about that Elios will prevent clinicians from developing the case conceptualization skills and other interpretive skills that they need to be able to document correctly. Has that been a concern to you? And if so, have you had any experience there?
So the way that we kinda do it is, for example, our interns, we do not allow them to use Elios. So our master's level social workers, our master's level counselors, because we are still working with them in their developmental processes, obviously, when they're in internship. So we don't allow our students to use it. Now, I have let a couple of my students use it towards the end of their experience after they've clearly shown me that they have the clinical skill to do it. As far as our staff, if we have new staff that come in, we have not held Elios back from them. Because our hope is that they have either done, for example, their peer specialist credential. If they're a case manager, they've had a bachelor's degree with some type of experience writing. If there's a master's student, they've done an internship experience. So while I hear that concern, I have also found that our staff are like, wow, first off, Elios makes me sound really, really smart. But the other thing I've heard is I was doing interventions this whole time that I didn't even realize were interventions, like Socratic questioning, or that they were using CBT techniques. And so I think we've also been able to use it as a teaching tool to help expand their clinical knowledge and help them see, okay, what you thought was chit chat is actually this clinical term, and this is the service you're providing. So I have seen it actually reversed. Yes, our interns, they have to show that they can write a document first before we let them use it. But for our other staff, we also use it as a tool to say, one of the questions I ask my staff is, what is an intervention that came up for you in your notes this week that you didn't realize you've used? And let's talk about it. What did that intervention look like? So, kind of that teach tell version, right? So that they can then explain their intervention back and then continue to use that intervention with other patients.
Yeah, yeah. And I think I always refer to that phenomenon as that these are competent clinicians who are doing these things as a matter of course. And the problem isn't that don't do them. They just don't think to document them. And Elios
Mhm.
reminds them, hey, you did motivational interviewing today or whatever that is. And they go, yeah, that's right.
Absolutely.
I guess I did, didn't I? But otherwise they wouldn't document it. And given all the pressures of documentation, it's not surprising, that they're trying to get a note done so they can get on to the next client. And I get it. So have you had any experience using this as a recruitment tool?
We have. So we actually, in our interviews, when we're interviewing clinical staff, we share that we have AI Elios supported documentation, that it reduces clinician burnout and things like that. So we have started using it in our interview processes, to explain expectations, but to also explain it as a benefit to working for the organization.
Has that converted your recruitment any better? I mean, is that
I personally feel like it has. I don't know if we've tracked numbers per se on it, Denny, but I can tell you staff are really excited when they come in the door and realize that they're going to have a supported documentation process, especially if they worked in the field before and are
exactly?
used to, how do I say this, paperwork first, then patients. So whenever they find out that we have this support, it has really excited them to walk in the door and see how it works, and see how it improves patient outcomes. And not only hiring, but retention, you know? When you start to have staff looking at, "Oh, I may leave the organization, but if I go to this organization, I don't have that support and I'm gonna have to rewrite all my progress notes," it helps retention too.
Yeah, yeah, yeah. So you're using individual, group, and mobile for
Mhm.
in your organization. Is there anything else on the horizon for you?
We have a few staff right now who are also testing assessment.
Okay,
Um, and so they have nothing but praises to sing about the assessment modalities. The only like feedback that I've heard was, Janice, sometimes it gives us so much we have to filter through it to figure out what we need. And I said, that's a good problem to have. I would much rather have more data and get to choose and be more proactive with what you want, in your note. They really like how we use the ASAM model, American Society of Addiction Medicine, which we have to write dimension summaries and things like that. And the assessments are kicking those dimensions out. Not only is it helping our staff write our summaries, but it's helping justify the rating scales that they're giving. So the staff that are testing that assessment model are loving it.
great. Yeah, and of course the ASAM dimensions are mentioned in the group notes as well. So you get
Hmm.
that kind of in real time for somebody who's in treatment, and you can see their progression through the ASAM criteria. That's
Hmm.
I'm pleased to hear your experience though. That's great with the assessment product. So when you think back on this, are there things that you wish you had done differently with your rollout or with your implementation?
I think some of the things that we kind of wish we had done differently is just getting involved in more products earlier. So, when groups came out, it was offered, assessments came out, it was offered. For us, we were like, oh, well, let's just do progress notes first and then this, and build on it. But the reality of it for us is that we probably could have rolled them all out at one time even and been just as effective, and our staff not felt like, okay, well, I can do Elias for this, but not for this and not for this type thing. I think the other thing we've talked about a lot, is that we've really liked our rollout, because we just feel like it involved the agency as a whole. Those champions I was talking about earlier were not just leadership. They were clinicians, they were counselors, they were case managers. So finding individuals in each one of the roles that you're hoping to roll out in, and finding a champion that can speak about that specific role and the way it integrates with Elios was really, really important for us. And I would encourage that for other agencies that are looking at rollout is, don't just have your leadership be your voice for it, have your actual clinicians who are using it. It really changed the culture. It changed the way that our staff looked at the program because it was a peer that they trusted, not necessarily just my manager telling me this is going to be a good thing for
Yeah.
you. So finding those internal champions in various roles, I think, is a very important part of rollout.
Well, I couldn't agree more. I think that's when we look at implementation science, the data supports that as well. It's like, if you have people who have internal credibility, however you define that, they have a bigger influence than say management, which I'm not saying people are skeptical of managers by and large, but they have heard us in leadership say, we got a tool here that's going to help you. It's called an electronic health record. It didn't help them. It helped
No.
us. It helped the organization, but it didn't help them. So,
Right.
so they've been bit before, and then so uh, fortunately this time I think we finally have a technology that has been built to help clinicians do their jobs. So what doubts would you like to address for like senior leadership who are saying, I don't know if this is the right thing for us? Why, our EHR vendor is selling an AI product. We'll just use that. Any advice about those kind of things?
While there are various AI products out there, which we also looked at, I think the one reason that we came back to Elios, and the one thing that I appreciated the most is in our implementation process. A shout out to Tabitha, by the way. I've worked with other technology implementation in my role. And I have never worked with a company that had things so outlined and said, this is what we're going to do. This is what we need from you. And the back and forth communication was invaluable only because you don't always get that communication with organizations. And so for me, it's all about communication, it's all about organization structure, and they did not make it any more strenuous on our staff to roll out because I don't need a product that's going to add stress to my staff. They already have enough to manage. And so for me, Elios just really fit the bill for us. And so through seeing that rollout process, even now we still have a customer support person that if I've sent a help ticket off and I don't feel like I'm getting a fast enough response, I can reach out to them. And we've had Elios now for well over a year. And so to have that ongoing support even after implementation, I think is very valuable. And you don't always have that. Our EHR, we send help tickets in and we may or may not get a response, or we don't know. They've sent it back in technical jargon that means nothing to us as clinicians. And so that ongoing support that we've received from Elias really made the difference for us as an organization. Um, the way that I look at things and the way that I want to share most is that if you're using a SUD system where you're a group heavy model, your most talented facilitators are the ones that are the most exhausted. And so when clinicians are overwhelmed, they start to do generic cookie cutter notes just to make it through the day. But when you provide this group's option, you really, and Elias overall, like you flip the script on that. So Elios handles that clerical stuff that maybe some of our staff are really not very good at. They're the ones that helps our clinicians stay in our clinician headspace and not have to switch back and forth to I'm somebody writing a document versus I'm somebody providing a service. What we found is that you get better notes, you have happier staff. Really, when you think about our documentation is built for auditors and people that come in and do our credentialing, not for our patients. And so Elios has helped that become a byproduct of the session and not necessarily the goal of the session. It's allowed us to make sure that we are capturing that golden thread, make sure that we are providing quality interventions and responses, and we don't have to worry whether our notes are going to pass the state auditor review. Because we can just focus on the services we're providing, and Elios helps us document and show the quality work that we're providing. And it takes that burden off of our staff. So when our counselors are looking down, for example, to jot a note down about what was done in session, they may miss a nonverbal cue. They may miss a tear slide down their patient's face, a micro expression, or even a shift in body language. Elios takes that away and helps us just be present and there for our patient and to catch all those nonverbals and to just provide quality services. So, if I could offer one piece of advice, if your staff is overwhelmed, SUD programming suffers from staff who are overwhelmed and burnout. So the time that you're able to reclaim through using Elios allows an agency to move from survival documentation mode into a center of excellence. So you don't hire your staff members to be clerks. You hire your staff members to be healers, and using Elios gives them a tool to be able to provide better services.
That's really a wonderful note on which to stop. So With that, Janice, I want to thank you again for being our guest today. This has been No Notes, and my guest is Dr. Janice Ruesler, who's been so helpful in explaining what their experience is at Gibson. Thank you so much, Janice, and thank you for being an Elios advocate.
Yeah, thanks for having me today.